so much of love, affection, warmth. So when Dr. Shajul requested me, Dr. Urunangsh requested me that you have to come here for this lung preceptorship, I always say that it will be a pleasure coming here. And I was requested to talk about radiation in non-small cell lung cancer. Now it's such a vast topic. So I said, now if I want to talk on role of radiation for non-small cell lung cancer, then I need at least 2-3 hours for talk on this. So I am requested to focus more on SBRT. I have nothing to disclose and I have no conflict of interest. My sincere thanks to all of you once again. My previous speakers have made my job a little bit easier by discussing a lot of things which I am also supposed to discuss, particularly the staging aspect. So I am actually conveniently skipping this because this was very nicely discussed. What are the changes from the previous AJCC staging and the current 9th edition of AJCC staging? The implication of this difference in staging is not only about change in stage, but also to decide about newer treatment options. And we all know that in current era, particularly in case of oligometastatic lung cancer, the treatment outcome has significantly changed. The treatment paradigm as well as the treatment outcomes, both have changed significantly. So I'll skip these slides. So this is the overall treatment overview. Stage 1, stage 2, we all know that wherever possible surgery is the standard of care and that's the gold standard. In stage 2, surgery followed by adjuvant systemic therapy. Stage 3, now because there is a change in N2 disease status, single station, multi-station. So surgery followed by adjuvant or neoadjuvant followed by surgery. Now in neoadjuvant, there are doubtful discussions between neoadjuvant chemotherapy or neoadjuvant chemoradiation followed by surgery. And alternative is definitive chemoradiation. Stage T4 and 3 disease, the standard of care is definitive chemoradiation. In both the cases, one can add adjuvant durvalumab as per, because we now have a very robust data to suggest significant improvement in overall survival. In both T1 and T2 or in stage 1 and 2, where surgery is not feasible, radiation as a radical approach is a standard accepted treatment option. Now the fractionation for preoperative radiation, although not very common but commonly employed in superior sulcus tumor, is around 45 to 54 gray with conventional fractionation of 1.8 gray to 2 gray per fraction. Most commonly used dose is 50 gray in 25 fractions followed by surgery. Definitive radiation in CalGB trial, it was showed that neoadjuvant chemotherapy followed by radiation is better than radiation alone. However, they have not used concurrent chemoradiation, and a meta-analysis by Operin et al. In 2010, it actually established that definitive chemoradiation is better than chemotherapy followed by radiation. It improves not only PFS, DFS, but it also improves overall survival. So these are the indications for definitive radiation: T1 to T3 and 2, T4 with any nodal station, unresectable early stage disease, or wherever the patient is unwilling for surgery, we have the option of stereotactic ablative radiation. Medically inoperable because of issues with anesthesia and refusal by the patient. Different dose fractionations have been tried. However, the standard remains 60 gray in 30 fractions with 2 gray daily along with concurrent chemotherapy. Dose escalation has not been proven to be significantly improving the survival, but it increases the toxicity. Dose escalation even with proton is now underway, and as of now we cannot say that proton is beneficial compared to conventional photon-based treatment. The probable reason of failure of dose escalation is most likely increased toxicity with higher dose of radiation. As of now, involved field irradiation or involved nodal radiation is the standard of care. There is no benefit of elective nodal irradiation. So IFI is the current standard of care. Accelerated hypofraction has not been proven beneficial. Lung adjuvant radiation therapy trial has shown that there is no benefit of routine adjuvant radiation in all patients. However, there are some indications like margin positive disease, R1, R2, or gross residual. Extranodal extension, questionable. Multistation N2, questionable. Inadequate lymph node sampling. Now there are different criteria for lymph node sampling adequacy. Three different groups have three different criteria: NCCN, American Cancer Society, and IS, International Association for Lung Cancer Surgery. So they have used different criteria. However, the number which they have defined is minimum 10 to call it adequate lymph node dissection. Both NCCN and American Cancer Surgery Society, they have recommended at least 3 stations with 1 at least intrapulmonary and infrahilar. And IALC has basically given, they have very much systematic in terms of location of the tumor, and as per the involvement of lobe, they have recommended very systematically which lymph node stations have to be sampled. The current NCCN recommends this dose fractionation for post-operative radiation when it is negative margin and radiation is indicated, 50 to 54 gray. Extracapsular nodal extension, 54 to 60 gray. Gross residual disease, 60 to 70 gray. Role of radiation in lung cancer for palliation has long been proven, and it can be used for local pain relief. It can be used for treatment of superior vena cava obstruction, to treat acute bleeding from the tumor, obstruction of the bronchus, spinal cord compression, brain metastasis, and any other indications where radiation can provide adequate palliation, like bone metastasis. And there are different dose and fractionations. The commonly used dose fractionations across the world are 20 gray in 5 fraction or 30 gray in 10 fractions. For only pain palliation, 8 gray single fraction is a very good option, particularly in countries where resource is limited. In most of the cases, when the purpose is pain palliation, 8 gray single fraction can be a good option. On an average, 6-month duration is achieved. The benefit of giving 30 gray 10 fraction is reduced requirement of re-irradiation in the same site for pain palliation. Now coming to the role of SBRT in lung cancer. It started in 1990, where Karolinska University first time they came up with their concept for SBRT, which is basically delivery of a very high dose radiation, very precisely to the tumor in a limited number of fractions. So this is basically a big shift from the conventional 30 fraction radiation or 33 fraction radiation, coming to either 3 or 5 sittings of radiation. And they have showed that a dose of 7.7 to 10 gray per fraction in limited number of 1 to 4 fractions is either as good, if not better, compared to conventional chemoradiation. And it also showed that it can achieve more than 80% control rate, which was hitherto impossible or not seen. The rationale which was shown or which was explained as a completely different radiobiological way of cell killing with high dose of radiation delivered per fraction in a very short time and in a limited number of fractions. So when we calculated the alpha by beta, the effective biological dose reaches more than 100, and the recommended BED for SBRT protocols are between 100 to 180. Now, these are the indications for SBRT, early stage non-small cell lung cancer, post-chemo radiation with a residual or recurrent tumor in or around the initial primary, initial PTV, oligoprogression in lung, oligometastatic disease, small cell lung cancer like T1, T2, N0, and ideally the tumor should be less than 5 centimeter, node negative, peripherally located, good pulmonary reserve. Now, as we have been progressing in terms of technology and our understanding and experience with SBRT, we are now gradually moving more towards central and ultra-central location for SBRT as well. So there has been a clear-cut association between BED and tumor control, and there are initial 2 studies, CHISEL and SPACE, which have actually used 2 different dose fractions. In CHISEL study, they have used 48 gray in 4 fraction and 54 gray in 3 fractions, and they have compared both these SBRT protocols with 66 gray in 33 fractions, and they have shown that SBRT provides a superior local control without an increase in major toxicity. However, the same data was not reproduced in space study where they have given 45 gray in 3 fractions and compared it with 70 gray in 35 fractions. Now there is this problem, 70 gray in 35 fraction, we know that it increases problem. And also the study was later on criticized for an imbalance between different prognostic factor patients in both the groups. So probably the randomization, the patient selection was not appropriate. And in 2003, Timmerman and other groups have actually shown that when the BED is more than 100, compared to BED less than 100, there is a significant difference in local control and 5-year overall survival. Now, if you can see here, when we can achieve more than 100 gray BED, the local recurrence rate at 5-year is only 8.4%. compared to 42.9%. That means 5 times more risk of failure. If you look at the survival, 70.8% 5-year overall survival compared to 30%, so more than double. And both of these findings were statistically significant. So whenever one should plan about doing SBRT or create an SBRT protocol in the department, every effort should be there to make that BED more than 100 gray plan. If one cannot achieve, then of course the tumor control will not be as per our expectation. So the classical indication is early stage inoperable. However, the debate is always there between what happens with operable. As a community, radiation oncology community always debates with surgeons that we do not get the good quality patient. You operate patients with best performance status and the patients having worst performance status is sent to us, and then also we provide you more than 90% 5-year survival with those poor performance status patients. So probably we would have been able to give you even better result if you would have sent the PS0 or PS1 patients. But I do not believe that this debate will ever end, although there are at least 2 randomized trials going on for operable lung cancer comparing surgery versus SBRT. Now, if you look at the 2024 NCCN, which has eventually not even changed in 2026 also, stage 1A and stage 2, the standard of protocol is wherever surgery is possible, the patient goes for surgical exploration, mediastinal lymph node sampling or dissection, and they also recommend that if a bronchoscopy is required, it should be done intraoperatively. And at the same time, patients who are medically inoperable, who are high surgical risk, and patients who do not want to undergo surgery after meeting a thoracic surgeon. This must be remembered. It's not the radiation oncologist counsel and the patient denied surgery. The patient must meet the thoracic surgeon before taking an informed decision that I want to go for SBRT. So also in both these cases, SBRT is acceptable. Now, SBRT has always been beneficial with reduced toxicity, and if you compare with a 30-day mortality after surgery, there is a 2.5% to 4.5% of risk, which is not seen with SBRT in properly selected patients in a center who are experienced in doing SBRT. And in operable lung cancer, we know that couple of studies started, but they could not finish because of lack of accrual of patients, because the criticism was surgeons never sent the patients to the radiation oncologist for the trial. So this debate will never end. Now, Timmerman has treated 33 patients. There were 26 T1 and 3 T2 tumors. The dose was 54 gray in 3 fractions. The primary endpoint was tumor control, and look at the impressive data. 2-year primary tumor failure rate was only 7.7%. 2-year estimates of PFS and OS 65.4% and almost 85%. However, the criticism here was almost 16% grade 3 SBRT related adverse events. However, the most of these grade 3 toxicities were either pneumonitis or refracture. Now, surprisingly, I was even discussing this today also, that the amount of chest wall toxicity, chest wall pain or rib fracture reported in the Western literature is not actually seen in this subcontinent. I am yet to see a patient post SBRT coming to me with a rib fracture. I have not yet encountered. Chest wall pain, again, very mild irritation for a very short duration after SBRT because of skin inflammation. However, the chronic chest pain is not that much again in our experience. Rosal and Stars, these are well-known studies which started this debate between operable cancer surgery versus SBRT. Both of them could not finish. However, an meta-analysis happened, and the meta-analysis showed that at 3-year, overall survival was 95% with SBRT, much better than 79% with surgery. However, again, this meta-analysis is criticized because the sample size was very small. It was not meant to be like that. And the meta-analysis was again had some errors in terms of different statistical analysis. However, we still cannot ignore this fact that if we ignore the surgical aspect and the comparison, 3-year overall survival was 95%. These data cannot be denied. So what are the concerns? Are everything all glorious with SBRT? Are there any concern or not? Of course, there are some concerns, and when they are not taken care of properly, they can be actually very challenging. The concerns are that SBRT not compared adequately with lobectomy in randomized control trials. What happens after 3 years? We are not having those data. 20% cases, there can be understaging because we are not going for mediastinal sampling or mediastinoscopy that way. The interpretation of surveillance or findings on scan after SBRT is challenging, and we definitely need a lot of experienced radiologists who are associated, who are tuned with interpretation of post-SBRT lung findings. And it is more complicated in terms of immunotherapy because immunotherapy can also create pneumonitis. SBRT can also give pneumonitis. And it becomes actually challenging to differentiate. And we definitely face this challenge quite frequently. However, as we all learn, even the nuclear medicine colleagues have also learned to differentiate which is radiation-induced changes, which are immunotherapy-induced pneumonitis, and which is possibly a recurrent residual disease. Salvage surgery when required post-SBRT always remains a challenge because you all know that radiation can cause fibrosis, and a radiated field always remains a nightmare for the surgeon, particularly in more tricky areas like mediastinum. Now there are 2 ongoing trials, one is TableMeds and one is Valor for operable early stage lung cancer, and hopefully the future will be more interesting for operable lung cancer early stage, and we may see that SBRT will be standard of care in coming days. Now for early stage inoperable cancers, we know that SBRT is already a standard of care. Now what is meant by inoperable? Inoperable as per the surgical RTOG criteria is baseline FEV1 less than 40% with predicted post-operative FEV1 less than 30%, severely restricted DLCO less than 40%, baseline hypoxemia less than equals to 70 or hypercapnia more than 50, exercise oxygen consumption less than 50% predicted, severe pulmonary hypertension, diabetes mellitus with end organ damage, severe cerebral cardiovascular or peripheral vascular disease, and severe chronic heart disease. So we have already seen those slides. I'll quickly skip this. Now, inoperable early stage lung cancer, Energy Oncology 0236 is one of the landmark trial, although it was a phase 2 trial. However, this study is one of the landmarks, and they have delivered 54 gray in 3 fractions. And central tumors with more than 5 centimeter size were excluded. So that's again a challenge for T3 tumors or bigger tumors when we treat with SBRT. However, there are now studies which are happening for bigger tumors as well. And at 5 years, we see only 7.3% local recurrence rate. 20% of local recurrences were involving lower recurrences. The 5-year overall survival was 40%. Grade 3 toxicities, 25.5%. And quite a lot of grade 4 toxicity, which is 40%. Now, as I was saying that SBRT for bigger tumors, particularly 5 centimeter or more, why it is a challenge? It is a challenge because larger the tumor size, higher will be the risk of regional nodal metastasis and distant metastasis. So in absence of a proper mediastinal evaluation, if we plan the patient's treatment based on only imaging, there might be a higher chance that we might miss those nodal disease and potential chance of cure which could have been given from radical chemoradiation and adjuvant durvalumab. The larger tumors entail increased risk of nodal metastasis. Bigger the tumor, bigger will be the volume of radiation, bigger will be the chance of pneumonitis. And at the same time, bigger is the tumor, there will be a higher chance that the tumor will be more centrally located or it will be close to no-fly zone. A meta-analysis of 88 studies with more than 7,000 patients suggested that age and tumor size were most important risk factors for development of pneumonitis. There is a paucity of data for T3 tumors like involvement of chest wall, involvement of pleura or pericardium. However, there is still data exists and it shows that at 18-month follow-up, you still have almost 60% overall survival with more than 90% local control. Now, the lacunae in larger tumors are limited data. We do not know whether to administer adjuvant chemotherapy in these tumors or not, as we administer in other stage 3 tumors or T3 tumors when we treat with chemotherapy or with definitive chemoradiation protocol. We also do not know whether we should add durvalumab in this situation or not. The upper limit of tumor size for SBRT is again not known. Very limited information for tumors which are 7 centimeter or bigger. And it is very important to adhere to the organs at risk protocol or the tolerance. It becomes difficult to achieve such tolerance or to achieve such dose constraints when the tumor size is big. So as I was saying that the trial is already going on, and probably once the result from the volumes trial is coming up, we should know about what happens with larger tumor SBRT. Now, 10 years back, when I was doing my registrarship in TMH, I remember Dr. Anushil Munshi, who is one of the leading persons in our country spearheading SBRT lung protocol along with Dr. JP Agarwal in TMH, used to teach us about this no-fly zone. And what is this no-fly zone? It's a 2 centimeter area within proximal bronchial tree. So we know what is proximal bronchial tree, and within 2 centimeter all around this, that becomes the no-fly zone. So we call them centrally located tumor if the tumor is close to this. And in Indiana series, although it's a phase 2 study, they have achieved some sort of protocols to even treat these centrally located tumors, and they could not found any difference in survival outcomes. However, they actually saw that there is a higher rate of toxicity, 27% versus 10.4% between central and non-centrally located tumors. So RTOG 0813 is a study which is actually designated for centrally located tumors. They have given 50 gray with a BED of more than 100. If you see here, the dose per fractionation was 10 to 12 gray maximum. And if we know in SBRT, there is single fraction protocol delivering 34 gray, there is 2 fraction protocol delivering 20 gray per fraction, 3 fraction protocol delivering 18 gray or 20 gray. So there are different dose per fractionations. However, in this study, if you see, it was limited between 10 to 12 grays, not more than that. In 50 gray region, the toxicities were not much. However, with higher doses, there was significantly more toxicity seen. Now coming to ultracentral. So as people started gaining more and more experience and confidence, so people started thinking about delivering the same concept and same SBRT for centrally or ultracentrally located tumors. Now this is even a smaller area within 1 centimeter from a proximal bronchial tree or anything within this entire area. So again, we all know what is proximal bronchial tree. You add 1 centimeter more, and anything in this region is considered as ultracentral. HILAS trial is specifically designed for this type of ultracentral tumors. Now here, interestingly, if you see, the dose here is 56 gray in 8 fractions. Now there is a completely different concept of dose and fractionation between peripheral and central and ultracentral. So as you will see that ultracentral tumors are located in a location where the risk of acute sudden bleeding from damage of mediastinal vessels are very high, or esophagitis is very high, spinal cord toxicity is very high. The dose per fraction is actually modest. Most of the studies, they recommend 10 to 15 fractions, and the recommended dose is something between 60 to 70 gray, with higher number of fractionations, with lesser dose per fraction. The grade 5 toxicity means treatment-induced death, 15% in this trial. Why one should not venture with a very high dose per fraction in ultracentrally located tumors? It looks very lucrative to fire one single node sitting in the mediastinum, but then that single treatment can actually cause loss of life for that patient. So there are different studies, mostly they are retrospective and phase 1, phase 2. However, the bottom line remains that number of fractions should be more protracted. It can be 8, it can be 10, it can be 12, it can be even 15. And the dose per fractionation should be modest. Most of the data do not recommend delivering more than 8 gray per fraction. So Sunset trial, again, this is T1, T3 ultracentral tumors where the PTV was overlapping with bronchial tree, pulmonary artery, or vein and esophagus. 4D CT with IV contrast is mandatory. Again, a point to note here, if someone wants to venture with central or ultracentral tumors, one must use some kind of motion management, otherwise it can be a catastrophe. 60 gray in 8 fractions was used, dose was de-escalated to 60 gray in 10 to 15 fractions in certain situations. Look at this hotspot concept. We radiation oncologists and physicists remain very aggressive in creating hotspot to actually destroy the gross tumor. However, majority of the studies where we have noticed more toxicity like death, it was later on seen that the hotspot was significantly higher. In some studies, it was as high as 150%. That means the effective BED should beyond 180 gray. So the hotspot should not be, one should not be overzealous in creating hotspot in central and ultracentral location tumors, and it is actually more beneficial for the patient if one can create an uniform cold coverage delivering not more than 120% at the center. Now, there are meta-analysis for SBRT in ultracentral tumors because having a randomized study for these type of tumors will probably never be possible. And here you can see the different recommended dose fractionations, 50 gray in 5 fractions, 60 gray in 8 fractions, or 60 gray in 12 fractions. I will not say that we keep on getting too many patients for these locations. As of now, in my center, which is one of the very high volume centers, I could do 2 ultracentral tumors SBRT, and I remain very scared. I keep my doses to 50 gray in 10 fractions. I do not go beyond that. I probably need more experience to gain my confidence. As of now, both of my patients, they are alive, although one patient developed systemic metastasis. He remained controlled, and one of the patients planning I have actually shown here. It was a nodal recurrence after surgery, and that was my first patient which I encountered for doing ultracentral, and we planned with all sorts of image guidance. We are equipped with optical imaging, we are equipped with 4D GET CT, we are equipped with exact-rec. So our treatment accuracy on board is inaccuracy is less than a millimeter. And in this patient, our margin was only 3 millimeter, again a very, very tight margin around the nodes. And we delivered 50 gray in 10 fractions, and we achieved local control of the tumor. However, the patient failed after 6 months with a systemic metastasis. Now, multiple lung metastasis, again a very challenging scenario, however not very uncommon in today's time. Most commonly we encounter from colorectal cancers. Although surgical resection of the metastasis is recommended, however not every time a surgeon agrees or the situation remains for surgical metastasectomy. SBRT can be a good alternative in these situations. However, so in this patient, we had probably almost 8 metastases. It's a colorectal tumor, a young guy, and it is almost 3 years now he is actually controlled in the lung. So this one you can see here, this is 95% coverage, and on the right side I am showing you here the 50% coverage. very nicely controlled spill, and this patient was treated with tomotherapy. And here we could not use 4D gating because tomotherapy is not equipped with 4D gating. So here we used a very shallow breathing. A very shallow breathing, we created ITV taking into account all the phases of respiration. So it's a 4D CT contouring on every phase or every beans of respiratory cycle, adding them up and creating an ITV and giving them a PTV margin. Another patient again, so this is a very recently treated patient who had primary adenoid cystic carcinoma in sinonasal region. We treated her almost, so it was initially operated, we radiated, had a local recurrence, I re-radiated, third time radiated, she remained locally controlled but developed lung metastasis. We did all kind of NGS, molecular marker analysis, liquid biopsy, we even had resection of one of the nodules to have information on the genetic aspects. Unfortunately, we did not get any targetable mutation to treat her with systemic therapy. And unfortunately, she could not even tolerate a very lowest dose of lenvatinib. So finding no other option, I had to challenge her with SBRT, and my challenge here was a combination of peripheral and central tumors. Now, when we treat with SBRT, we remain very vigilant about the organ at risk, and we strictly follow the OIR constraints. We have, you all know that there are multiple guidelines, multiple OIR dose constraints coming from US, coming from Europe, and we have all of them, and I usually try to start with the most stringent one. If I can achieve, I am very happy. If not, then I go to the second one. So that way we planned this patient with a little bit lower dose for the ultracentral one and a little bit higher dose with the peripheral ones. But for me, again, rib and chest wall was a constraint for which I could not achieve more than 45 gray in 5 fractions. Now, the ISRS guidelines for ultracentral tumors, they recommended 60 gray in 8 fractions or 60 gray in 15 fractions. Motion management is mandatory. Hotspot to be avoided. Limit the global Dmax to less than 150%. Prioritizing sparing of organs at risk rather than achieving target dose. This is the crux or bottom line of planning central and ultracentral. And if there is an endobronchial growth, one should not venture, or one should be very gentle in dose perfectionation. Very practically important thing is to avoid anticoagulants at the time of SBRT for central and ultracentral tumors. If the patient is getting immunotherapy, then at least wait for a week before starting immunotherapy and after, at least 1 week after finishing SBRT. If the patient is getting some kind of TBI, then some kind of TKI, then we recommend at least 3 days of omitting TKI before SBRT and 3 days after finishing SBRT. Lung volumetric parameters for tolerance must be maintained. We'll quickly skip this. However, we must say that for oligometastatic non-small cell lung cancer, you can see that with SBRT and without SBRT, the change. The overall survival with a consolidation SBRT arm in these series was 40 months versus 17 months. And if you look at the other trial by Iyengar et al., the PFS was 9.7 months versus 3.5 months with and without SBRT. So oligometastatic situation, SBRT must be taken into account. Cindus trial was another trial where they have used concurrent SBRT along with TKI. However, there are data to suggest that when you are using primary and metastatic sites at the same time, it's better not to fire the metastatic sites, treat the primary, that improves the outcome in a better way compared to primary plus metastatic sites. So there is meta-analysis for that also. Now, recurrent disease is again difficult to treat. However, re-SBRT is possible with an experienced, in an experienced center. I'll skip this, salvage SBRT. Immunotherapy and IO is going to be very interesting in coming days. We do not have guidelines as of now, so we must be very careful. It might be beneficial to use IO in one way that because they can be synergistic, so we can actually reduce the dose of radiation while patient is on IO for central and ultracentral tumors. That might be saving the patient from grade 5 toxicity. These are the different dose recommendations, and getting a patient for 34 gray single fraction is every radiation oncologist's dream, but it's not so commonly available. As of now, in my center, I could get only one patient where I could treat with 34 gray single fraction, and you can see this is a very small recurrence. This was a primary oropharynx having a long DFI, single isolated lung mets. We planned for SBRT to the lung mets, and along with systemic immunotherapy and chemotherapy. And you can see that the spill and everything was very well controlled in these patients. However, treating with 34 gray in single fraction is extremely challenging. It requires a lot of setup, lot of accuracy and technology and experience and expertise, both on the part of medical oncologist, radiation oncologist, on the radiation physicist and technologists. Quickly going to prerequisites, immobilization. These are the different gadgets for immobilization. Cyber knife, I have no experience of treating with cyber knife, so I will not go on that. Active breathing control, dampening with abdominal compression, and 4D CT. Now, most commonly, we have created our targets on the MIP or maximum intensity projection. And at our center, we use 4D gating with abdominal tracker. We divide the respiratory cycle in multiple bins. Most common way to do it, divide the one cycle in 10 bins. You keep on taking the scans with a preset amplitude, at least 1.5 centimeter to make it a success. Ideally is between 2.5 to 3, so that the patient can remain comfortable, can hold the breath for at least 20 to 40 seconds. And that can give you inflated lung, reducing pneumonitis. Now these are different phases of respiration. Now when you are dividing them in different bins of 10, you are accumulating all the data of imaging for that particular cycle of a phase of respiration, and you are contouring on every cycle, every phase of those bins, and then you are creating the ITV. Personally, I prefer doing DIBH because that keeps the entire movement of the lung standstill. The patient doesn't move, the lung doesn't move, the chest wall doesn't move, the lung is inflated, so my radiation volume in a normal lung parenchyma remains much lesser. So this is how we use our patient's fixation device. We do not use a complete thoracic cast. We fix the neck and shoulder so that the chest can expand anteriorly completely. So this is one practical aspect one must remember, that do not make a very tight cast when you are planning DIBH. You can make a very tight cast with abdominal compression if you do not have DIBH and you want to make a small ITV. So in that case, a shallow breathing with tight cast may be more beneficial. So that's how our workflow of DIBH, starting with a coaching for 2-3 days about the breathing pattern. We fix the amplitude, we train the patient, and we keep on training even after doing the simulation scan. After acquiring the simulation CT, we contour, we plan, and the patient goes to the treatment. And on every day, the patient is actually trained about how to maintain the same pattern of breathing, and this is the most important part to make a DIBH plan successful. We do DIBH not only for lung SBRT, but DIBH can be done for any other mediastinal tumor, left-sided breast cancer. There are so many indications. However, the basic way of doing DIBH, maintaining the breathing pattern, remains the same. So to summarize, the radiation plays an integral part in all stages of lung cancer. Conventional fractionation and hypofractionation with SBRT significantly improved overall outcome in managing the lung cancer. With modern technology, motion management, and evolving knowledge, SBRT is gaining more and more momentum and becoming invaluable in the treatment of lung cancer. Tumor location, size, stage, baseline lung function, and comorbidities play an important role in deciding the mode of radiation delivery. However, one must not forget that the most important key here is proper patient selection and having a properly trained team of radiation oncologists, radiation physicists, radiation technologists, and other pre and paramedical staffs as well, who will be part of the whole journey of the patient. Just for your sake of interest, we also run a couple of fellowship programs and observership programs on advanced radiation oncology. If any one of you is interested, you can come and you can connect us. We have a variant edge with hyperarc. We are also going to start functional SRS. We have SRS cone. We also have a tomotherapy with all sorts of gadgets, and this is my team. So my sincere acknowledgement to my fellowship mentors from US, my whole team, my colleagues, my patients, teachers, my family, and to all of you. Thank you so much. And this is my team of doctors who are working with me.